Here it is. Here he is. And there he is, guys.
Hi.
Dr. Joshua Schiffer, everybody, without his glasses. He's actually a form of Clark Kent. He was just being a superhero. And now he's back to being a mere mortal. It's been a while, Doctor. How are you?
I'm doing all right. How are you?
I'm all right, still at home. Sheltering in place since I am not essential. Either hardly anyone in Hollywood is. So actually, that's actually most of the time.
Yeah.
But you are essential, and you've been going to work every day.
Yeah, I'm about 80% of the time at home and 20% in the clinic. But the need to go to the office is pretty small for the research component of it. So yeah, I'm at home quite a bit too.
You sit on a laptop most of the time?
I spend an inordinate amount of time on my laptop. If I were to lose it or break it, it would be a personal disaster. Yeah.
All right, now we know how we can get to Dr. Schiffer. Do you have one of those ridiculous treadmill desks that everyone got for a moment and then everyone stopped using?
No, no.
Not yet.
I saw
Not
through
yet.
that.
Stay in shape.
I do have a bouncy ball.
All right, well,
yeah.
Oh, you do? You sit on the bouncy ball?
Yeah. I don't sit on it, but I have one, in terms of products that I've cycled through. Yeah.
I would like you on some serious medical and scientific call as you just slowly bounced up and down like a 6-year-old at a preschool. That would be terrific. We give it a whole different flavor to the Zoom call. So let's get to it because I think we got about 55 minutes here if people are hanging in there. And I told people to list some questions. I'll try to keep up with them. But, we haven't done this in a few weeks and things have gotten pretty awful. And it is, I felt like the last time we talked, it was looking positive, like we were containing it to an extent, but clearly that was not the case. We had 36,000 cases in one day this week, and that we broke the record, and the European Union is averaging 4,000 a day. That's the entire European Union. So can you just speak to what you think is going on and what happened?
Yeah. What appears to be happening is that there's a little bit of variability between states, but if you look at the pattern across states, the number that we're always following is this effective reproductive number, and that is the number of cases that the average person infects. And throughout most of the planet, that number's gone to less than 1, and in the United States, it's hovering somewhere in the neighborhood of 1. And in the states that are, starting to make headlines for problems, Arizona and Texas, and even within those states, it's not quite. The outbreaks are focal, so some parts of those states are in much better shape than others. Those are states that are above this number of 1, and then there's certain states that are just below. And it's problematic for a couple of reasons. First of all is that in certain places it appears to be enough to be really putting pressure on the hospitals. In our state, Yakima is having a very difficult time at the moment. And the second issue is that it is a very thin margin of error in terms of moving into a really rapid spread of the virus, where it's doubling. The number of cases is doubling every week or two, and so we're really skating on thin ice right now. The reason why it happened is tricky. My opinion is that we have reopened a bit, probably too soon, and perhaps a bit carelessly, and it's the the message that's coming from the executive branch is not at all helpful. It's not at all helpful to cast doubt upon the things that we know work to some extent, particularly masks, particularly avoiding crowds inside. And so, it's not, I don't think we're in an emergency phase, but it is not ideal where we are right now. And it puts us in, we're really close to being in a situation where it could take off again. One way to think about it is that we never really got out of the first wave. We're still in this sort of plateau. And the problem with that is that it takes a lot less to go from that plateau into a full-on second wave, but also that there are a lot of cases and unfortunately deaths that will be associated with the plateau phase, even if we are able to maintain where we are.
Right. And so if we're having 25 to 35,000 new cases a day, that's not a plateau anymore, that we're going to quickly blow right through where we were, at the height of it, obviously. Or is that, the plateau, would you call this a week of plateau, or this is a week of spiking?
It depends on the state. Certain states are really starting to spike, but again, in very focal ways, so not across the entire state. There's not the level of growth there was, say at the beginning of the pandemic in Wuhan,
Okay,
where they were doubling cases every 4 or 5 days. There's nothing like that. But
okay,
I have seen numbers of every 2 or 3 weeks in Texas, which is really, not at all sustainable, and not sustainable for their hospitals. And it doesn't provide a very good platform for the fall if we're really serious about doing things like opening schools, even in a moderate
right.
way. It really puts us in a poor position to do that. And, it's not good for the economy either, because we're
No.
frankly going to be in a situation where we have to be much more restrictive. And so I wish I could be more positive. It's, the
No,
one
I want you to
positive
be
thing I've seen,
realistic.
yeah.
What were you going to say? What was the one
It's,
positive thing?
that there are examples across the globe that this is a doable thing. What Australia and New Zealand have pulled off, what Vietnam has pulled off, what Japan has really successfully done, where the number of cases are very low, and they're really now in a situation where they're putting out very, very small forest fires periodically. It speaks to the fact that there is a world in which we can do a lot better. I wish I felt that this was, being prioritized at the central level, and that we were getting messaging that is supportive of trying to put this to bed. But that's not what I'm hearing. So,
Right. And I keep hearing people keep saying, well, our country is really big. But then I go, well, if the European Union can drop it down to 4,000, or if you're South Korea that has a very dense population, and I know that everyone said they had a spike this week, but it was, compared to what's going on here, it's very little. So it's possible.
yeah, it's little. And what is very clear after these spikes happen is how on top of it they are. When there was this report of a small secondary spike that constituted an outbreak at a nightclub, their
Hmm.
epidemiologic reports, which they swiftly published online in both Korean and English, were so comprehensive. Where they were really tracking every single case, and you just got the sense, looking retrospectively at what they had done, that you're like, yeah, they're dedicating significant resources to this. They're taking it very seriously. And despite the fact that, our public health departments are, particularly in the Pacific Northwest, really, really strong, when you have this many cases circulating, it's very hard to do that type of tracing. And it really speaks to the fact that in order to put this, to control this in a really comprehensive way, you need the cases to be at a reasonably low level. And, you know, this concept of this being, you know, the United States being a kiddie pool and you can't pee in one side of the pool and not expect it to spread to the rest is really true. So, you know, there are areas in the country, Seattle, we have very few cases right now. You know, the hospitals there are very few sick people with COVID in the hospitals, but it doesn't seem sustainable to me in the sense that if, you know, the rest of the country is having problems and people are starting to travel, that we can really keep this down.
So if you're the king of the world, or you're the king of America, what do you do? What would you do today to start squashing this thing again? What would you do? I mean, I know you say contact tracing, which we should be putting a gajillion dollars into that, and it doesn't seem like that's happening right now. But would that be, I don't know, first step, or ramp up testing everywhere?
Yeah, I mean, first of all, you would not want me doing this because you know, my frustration would leak over, and I would be a mess up there. And so the first priority would be to not have me giving the message. But you know, I think the model that I've seen is that the Prime Minister of New Zealand, who every day would get online and give an update that was scientifically based, that was compassionate, that was understanding. You know, she really went out of her way to, you know, what, like, masks are a perfect example in this country where there's a subset of the population who are not wearing masks and are against it. It's palpable. I mean, we took a trip to a more conservative part of the state to get away and, you know, get out in the ocean. And we were wearing masks in the supermarket, and 10% of people in the market were wearing masks at best. And we also got some nasty looks. And so for wearing a mask. And so the messaging has clearly gone off base. And it's just, you know, I think you can send, this shouldn't be a partisan issue, right? I mean, really, it's a pretty straightforward message to say, listen, we can't precisely say how much this works, but we know it works, and you're doing this to protect your own family members, your own elderly family members. It's not controversial. This shouldn't, and so the fact that our messaging is so off base, and so really, I just think you need the right leader with the right set of skills, who understands scientists, who respect science, and who can speak with some degree of empathy and compassion to a wide swath of the population. I think that's the ticket to do this, particularly while we're, you know, treading water waiting for biomedical interventions. You know, I think that, and what we're going to see in these countries is that they're, you know, in Australia and New Zealand, that if you're very disciplined about this for several months, then you can open up with some degree of safety. And, you know, that going back to school for those countries will be a lot less onerous of a task than it will be here, where, you know, I have some access to the modeling that goes behind trying to make these decisions, and it is not easy. I mean, with this number of circulating cases, there's a trade-off between opening schools and accepting the fact that will result in more cases and deaths, without question. And so, you know, and it's it's potentially a manageable situation, but why put yourself in that situation at all? You know, why not have more discipline up? So, but I'm not, you know, I guess I'm not terribly optimistic that that's going to happen here. In the next months.
And I also read that for every person that tests positive in the United States, there's 10 other people walking around with it that are not even tested, but that it's way more prevalent than we think.
One of the trends that's happening, which you could paint this with a glass half empty, glass half full, perspective is that the current caseload is much higher among young people than it was before. So the proportion of cases involving the elderly and the most at risk has gone down. And so the good component of that is that the case fatality rate will likely go down as a result of this, because a higher proportion of people getting infected can handle the infection and not end up in an ICU. The downside is that these people are the most likely to congregate, the most likely to spread the virus, and the most likely to be asymptomatic or mildly symptomatic, and so are a much harder target for public health. And that's a trend that's been recapitulated really across the country.
Yeah. Does that mean? Oh, go ahead.
Oh no, go ahead.
No, but so we've heard about herd immunity and all that. Does that mean, which needs to be about 60 to 70% to have this herd, to have antibodies that'll fight it? But are we just going to get there in a herky-jerky manner if we're going the way we are? Is that basically what's going to happen? Just kind of a crazy, out of control version of it?
I don't think anybody can project that. There are a couple of points to make, though. The first is that there's somewhat of an esoteric argument in the academic literature about what the true basic reproductive number of infection is for this virus in different parts of the world. And what that number is that's at the very beginning, before you do anything. How many people does the first person who's infected infect on average? And the reason that matters is it tells you when herd immunity starts to kick in. So if that number is much higher, there are a couple of very good scientists who think it's as high as 5, then it means you actually have to get to about 80% before herd immunity kicks in. There are other people who think it's more in the range of 2 to 3. And if it's 2, for example, you need to get to about 50% to get to herd immunity. So that's one of the reasons why epidemiologists are really, why that debate matters so much. The second thing about herd immunity is once you get herd immunity, it's not like it's over. There's still plenty of cases that occur beyond that point. So it's not a great solution. It's a great solution when you're thinking about implementing a vaccine that works, but it is not to arrive at that place, as you say, herky-jerky with waves after wave of infection is not terribly, I don't think that should be the public health goal of any country. I mean, even countries with very little resources should not take that approach. I would be, as sort of pessimistic as I am about the next 6 months, I'd be very surprised if that's what happens in the absence of a vaccine. I mean, I'm really hoping we will have, a vaccine that's can help out a portion of the portion of the population that hasn't been infected yet, whenever that comes. But
and right. And do you think the AstraZeneca vaccine, or they're in phase 2? Do you think that? I think they're in phase 2. Do you think that's the most promising? I mean, I know we've talked about that before, and we don't hear. Obviously, they're working on it, but is that the most promising one? Do you think?
I'm a little reluctant to try to guess which one's the most promising. They're all okay. I think the last I heard, there's 16 vaccines that are now in human trials. I think that it's my hope is that if this is a good vaccine target, that there will actually be more than one vaccine, and that there will be some nuance about both production, as far as ensuring that there's scalability of the different products that are made, and second of all, really catering the vaccines to different populations based on risk factors, based on scheduling of vaccination. So, for example, certain vaccines might need to be given twice. that's there's some concern about that with the AstraZeneca vaccine. And so that works pretty well. Giving the vaccine twice works pretty well in a situation where you have a relatively low incidence of infection and you have time to do that. So, you know, if we had that vaccine in hand right now, Seattle would be great for that. You know, we're likely not going to be having high levels of circulating infection in the next month. So you could hit everyone at month 0 and
Right.
month 1. But if you're considering delivery of this vaccine to less resourced parts of the globe where you really have the opportunity to go to a village once, then it's not optimal. And, you know, if you're dealing with, say, an outbreak in a nursing facility where you already know you have a case, and, you know, then maybe one vaccine is an option, but even better would be something you give that would provide protection more immediately than a vaccine, something like delivery of an antibody. So all of it, what my hope is that we don't
Right.
just emerge from this with one product, but we emerge with a number of products that complement each other well, in terms of who you give them to and how often you need to give them, and even side effect profile as well.
So, right. So, do you think, as far as once there's so much news about it, and I know you have already talked about it, about people that are testing positive again, that it's not necessarily once you've had it, it's gone. You're now immune. Can you talk about that? And because I think people who've had it walk around feeling like, man, I can just go do anything I want now. Can you talk about that a little bit?
Yeah. Let me tackle it from several angles. The first is that we now know that depending on the test you use and depending on the population you study, that the median duration of shedding, if you're infected, is at least 3 weeks, probably longer. Meaning that if somebody gets infected and you sample them a month later and they're still positive, and by positive I mean from a nasal swab you detect the nucleic acid or the RNA of the virus, that does not mean they were reinfected, and in fact is much more likely to be just the smoldering embers of their first infection. And there have been many case reports now of this going on for months, you know, even as long as 4 or 5 months, without any apparent harm to the person who has it. It turns out to be actually a big hassle in the hospital, because when we're admitting patients to the hospital of all variety, you know, women who are about to give birth, routine surgeries, whatever, they get a COVID test. And, you know, initially we were isolating every single person who came back positive. But now if we have a documented case 6 weeks ago and they come back positive and their viral load is very low, I'm hoping we're going to move towards a situation where we treat them, you know, more or less like any other patient, because they're very unlikely to be infectious and the virus is unlikely to be doing harm. So that's the first concept to consider. The second is whether somebody gets infected, are they at risk of getting reinfected? To my mind, those studies have yet to be done in a way that is convincing, simply because for that to happen in a way where we get enough numbers to really study this, I think what we need, and I'm not wishing this upon anybody, is really a second major outbreak in a place where there's already been a major outbreak. So in this country, I think the Northeast would qualify. So if New York or New Jersey gets hit very hard again, and you start to see people who clearly were, you know, infected 6 months ago and now have a new infection, and you can sequence the virus and say, okay, they're totally different, then that's evidence that the person has been reinfected. We've yet to see, in my view, a definitive case of that. The thing to keep in mind is just because somebody gets reinfected does not mean that they will get nearly as sick the second time. So it's possible when they get sick the second time, they might They might not develop symptoms at all. They might shed the virus for a very short period of time, and they might not even be very contagious. And so that, I think, there's this distinct possibility that we'll observe that, but we'll have to see. The other thing that people are getting very interested in, and there have been a number of really good studies that have come out in the last couple of weeks about this, several from China, looking at the antibody responses that people who have known infection develop over time. And what an antibody is it's a protein produced by cells in your body called either a type of memory B cell or a plasma cell. And they're just these factories that just produce these proteins that bind lots of things, but they can bind viruses and prevent them from infecting cells. And they can bind infected cells and serve as a marker for other cells to come in and kill them. And for a lot of vaccines, we can use those, we call it a surrogate. So if you, for example, if somebody gets a hepatitis B vaccine and we look for a certain type of antibody against the virus, we can say, okay, the vaccine took, it worked, and we now know that person's protected. And so people have been very curious about looking for these antibodies in people with infection and following their levels over time. And very clearly, almost everybody who gets infected develops an antibody response if you follow them at the right time intervals. But there is a trend towards people who have mild infection or asymptomatic infection not maintaining their antibody response over a period of months. And it's really variable. You know, there are tons of people who have asymptomatic infection who do maintain that antibody response. And so one big point of curiosity for all of us is twofold. First of all, if people have those antibodies, are they protected? Second of all, if they've had prior infection, but their antibody response goes away, are they still protected, but we just don't have a sensitive enough measure to look at this question? Both of those questions are unknown. I would, you know, if I had to put forth my best guess at what the future will show, I would suspect that a vast majority of the people with antibodies are protected, at least to some degree, against reinfection, and certainly against severe reinfection. I could be wrong about that, but that just seems like the most likely outcome based on other infections. And then the people without antibodies, there's so much, there's other components there's other arms of the immune system. There are T cells that are critically important for fighting infection. And I would be very surprised if even the people who have lost their antibody response are not at least somewhat protected against having severe infection the second time. But these are going to be really important studies, and they have great importance for vaccines, because if we prove that you can get reinfected, even if you have good antibody responses, that sets a very high bar for vaccines, and it might give some indication about whether we need to vaccinate twice. There's the other thing with some of the vaccines is there's something called an adjuvant, which is a type of immune stimulant. It's like a chemical that can be given with the vaccine up front, that rather than so what a vaccine tries to do is mimic the infection, right? So you're giving a protein, or you're giving something that will make a protein that looks just like the virus, so that you generate a number of immune cells that will take that as a decoy and then respond to the actual infection. But in the case of in the case of the adjuvant, what you're really it's less specific. It's just trying to rev the immune system up in general. And there have been a number of cases over the last decade of adjuvant vaccines being very, very good. The most famous of which is the Zoster vaccine. And so that it might mean that we might, for example, need to dose vaccines more frequently. We might need to add an adjuvant to make it more effective. And they're really important trade-offs to consider, because often, most vaccines are largely asymptomatic when people get them. But if you add an adjuvant, often people won't feel great for a day or two, because you're really you're really revving up your T cell response a little bit, and so the body can react. The zoster vaccine, that's its sort of Achilles heel. The new one is extremely effective, but it does have a worse side effect profile in the first 2 days after the vaccine relative to many of the vaccines we give. So that's why we care about all this stuff, because it really gives us some strategy to think about for the next round of vaccines after the first set of trials.
Wow. Well, feeling bad for a couple of days, think would be worth it if you could keep the virus away. Now, can you talk a little bit about blood type and how some people are more susceptible than others? I think it was people with type A, or more. They'll have more severe.
I have not read those studies carefully enough to say anything beyond what I've read in the press. I think that just looking at it from a kind of higher altitude, there is really intense interest about why certain people have more severe infection than others. And for infectious diseases in general, there's never a clean answer, unfortunately. In very rare cases, there is.
Right.
But the way we typically divide this up is, first of all, to think about the virus. And so some viruses mutate very, very quickly. And so, for example, for HIV, there's some very good literature that suggests if you get infected with a virus that has a particular mutant, you might have more severe infection that progresses more rapidly than another. That there's a little bit of a story developing there with SARS-CoV-2 that is not a complete story yet, where there's a mutation that popped up in Europe, but not initially in Asia and not in Seattle. But that same mutation traveled back from Europe to New York. And in a plate of cells, nobody knows if this is true in a human or even an animal, but in a plate of cells, that virus is much more infectious to the cells than it is than if you don't have that mutation. In people, it doesn't necessarily lead to more severe disease, but there are some virologists who think that that mutation allows the virus to be more contagious, not more severe, but more contagious than if you didn't have it. And I suspect that there will start to be stories that emerge that will take a while to sort of clarify about maybe certain mutations make the virus more severe than others. But as of now, there's nothing. The second feature of the virus that you and I have spoken about in the past is the dose, right? And that is the idea is that if somebody gets a really big exposure. So this whole thing can definitely start with one virus entering one cell, but there's an idea that maybe that would be a far less severe infection than if you had 10,000 viruses that start this off and you just have a much larger forest fire. I think that idea is gaining traction, both in terms of just observations that people have made, that with healthcare personnel who appeared to have gotten very large exposures and got very sick, but also in animal models of infection. I've started to see some evidence in studies where they gave monkeys different doses, and the higher dose monkeys had higher viral loads and got sicker. So that's on the virus side. Then there's on the person side. And so, some of that is starting to emerge in terms of what are called medical comorbidities. So those are things like diabetes and chronic lung disease and coronary disease. And all of these things appear to be risk factors for doing poorly, particularly coronary disease and having heart disease. So that is one risk factor. But then there is a whole nother set of risk factors, and this is finally getting back to what you asked about, which is features of somebody's immune system that often the thing that people look most closely at is something called HLA type. And what that is that's a receptor or a molecule on a T cell that is responsible for presenting little bits of the infection to other immune cells to activate the immune response. And for many viral infections, and also for things like tuberculosis,
HLA.
people who have worse, certain HLAs are much more successful at controlling the virus than others, and certain people are much worse at controlling virus. Mm-hmm. And what's really interesting about HLA is it's pretty specific to the given pathogen. So you might have somebody who's sort of been cruising through life doing very well, and they get exposed to HIV and they do much worse than the other person who gets exposed to HIV because of their HLA. But I will do my due diligence and try to catch up for the next time we speak, but I haven't read anything yet that really makes me convinced that.
Not at all. Well, yeah. And what does HLA stand for again?
Human leukocyte antigen.
What does HLA stand for again?
Human leukocyte antigen.
Wow. Yeah. All right. I'm not going to even try to write a leukocyte antigen. Okay. And so now, as you were saying, like people with diabetes, obviously compromised immune systems. And now I'm reading that people that are obese or have a BMI higher than 30 are they more susceptible, or are they more, or is it might mean the infection is more intense, or are both factors in there and it depends on your viral load?
I think it's more a question of intensity rather than susceptible. The data I've seen on susceptible has less to do with biologic factors and more to do with demographic factors. And so, the susceptibility, other than this mutation story, which in my opinion is interesting but not definitive at all, for susceptibility, it's mostly been race in this country, which then correlates back to demographics and having a higher proportion of essential workers, and so things that in my view are more tied to societal structure and less to biology, whereas the severity is really a mix. I guess the larger point I was trying to make about severity is that everybody you talk to who gets infected says they want to have a story, so they'll say, my infection was really mild, I think it's because of this or that, but it's so hard to know because there's so many factors that come together to sort of seal the deal about where the trajectory of somebody's infection. And you can't just take one variable and predict. I mean, you can say, okay, obesity is a risk factor, or having this HLA type is a risk factor. But despite that, there are plenty of obese people who get infected and are barely symptomatic. There have been, stories of 98-year-olds who get infected and it's like, a wimpy cold and they feel better 2 days later, healthy, and run marathons who get critically ill and nobody knows why. So, there's so much we don't understand, and it's within infectious diseases, understanding the spectrum of severity is one of the more complicated areas, and the answers are it's always multiple factors that really determine that.
Right. And we spoke about this last time, and this is the first time I saw you, I feel like genuinely worried, was when flu season hits. And I want to repeat this over and over again because you seemed very adamant about it, and that because flu season is just right around the corner, and we better watch out, especially with the way that cases are going up, and we're not, and there could be a second wave on top of all that.
I think the major question with flu is whether it will track very closely with COVID, there really is the social distancing measures that work against the COVID should work very well against flu. And so there are factors independent of social distancing which drive the severity of a flu season. But, you know, if the worst case scenario happens and we get hit by a big wave before flu season and we're all in lockdown, I would be pretty surprised if there's much flu at all. But on the other hand, if we're kind of in a place where we try to open the schools and it fails and there's a big outbreak, then, you know, I could see the two tracking together very closely. So, you know, it's critical that people get their flu shots, as we talked about before, and it really could be a disaster, but it should respond to social distancing. There's one really interesting difference between the two as far as the epidemiology goes, which I think has been a big surprise for a lot of people, is that there is for flu, there's a little bit more uniformity according to the level of contagion that an individual has. Whereas for SARS-CoV-2, there's been a number of papers that really show that the majority of people who get infected don't infect anybody. You know, the estimates are somewhere between 60 and 80% of people who get infected simply don't infect anybody. Whereas there are these super spreader events which keep on popping up in, you know, bars and fishing boats and prisons and military bases and old age homes and you name it, where it appears that one person can infect hundreds of people. And there's also suggestion that about 20% of people are responsible for 80% of infections. And so there's something unique about the virus where there's a little bit more of a propensity, you know, if the wrong person happens to be in a crowded place inside, that person is much more infectious than the same person would be with flu. So there might be some differences in how the two track based on that, but I'm not sure. It's really hard to project.
And why you talk about these super spreader events, and that usually comes down to one person that has it that does it, or it's too hard to. There's so many
sometimes you can tell,
into
sometimes
it
you can't.
That
there have been,
it's hard to say.
Again, Korea has done these. They had this study in and one employee was infected, and they have this paper where they showed where this person sat, and then they diagrammed every other person who was there that day and how likely they were to get infected. And so many people got it. I can't remember if it was 60 or something, but so many people got infected there. And there was a clear relationship to their proximity, both to where he sat as well as to the restroom. And so there's some question about whether there was spread within the restroom as well. But so for some cases, it's very clear it's one person. For others, it could have been several people who contributed. But it's a property of this infection that is different from influenza, for sure. And at some level, you know, oh, go ahead.
I saw. No. I was someone just asked if smokers are more susceptible to it.
Yeah, not that I'm
but
aware
from
of.
I think what you're saying is it's hard to tell at this point.
There was some data from France that suggested that smokers who don't have underlying lung disease might actually do a little better, but it wasn't very strong data, and I haven't seen that repeated in other studies. But yeah, to me, the susceptibility issue has more to do with societal factors than it does with biologic factors. I'm sure there are exceptions to that, but you know, it's really the people who are at highest risk at the moment are either people who have no choice. So I would say essential workers. You know, if you're working in a skilled nursing facility and 30% of the residents are infected and you are responsible for cleaning those people and feeding those people all day long, you're at very high risk. And then, of course, you have to get on a bus to get to work. Relative to a person, you know, a white-collar worker who gets to work from home.
Right.
Or even a healthcare provider who takes care of COVID patients but gowns up very carefully and is in the room for a minute. I mean, it's totally different. So I'm really, to me, the risk is very much related to the contact network within society. And then, of course, there are people who willingly put themselves at risk. So people who are going to bars and casinos and not wearing masks, that's, you know, a whole nother group of people who are putting themselves at risk. But it I think has less to do with biology than it does just what they're doing on a day-to-day basis.
Right. So so could you speak to, because I've heard, obviously we're hearing things like, hey, it doesn't seem like that's a big deal. Only 1 in 20 people go to the hospital. It's not that bad. But when if you could speak to this, because if people are walking around and their symptoms aren't that bad, they're still contagious and could infect someone that could die. And it just seems crazy to me that people would be somewhat okay with getting it, or just kind of a nonchalant attitude towards it, because it's highly contagious. And if one person doesn't have bad symptoms, but it infects 100 people, that's 5 more people in the hospital, and the hospitals
I think
will
you
be
stated
overwhelmed,
that very well.
which is what's happening now.
I think that the primary reason to avoid getting infected is an act of kindness and an act of goodwill towards your fellow human.
Right.
You know, particularly if you're not at high risk of, you know, of developing severe infection. I would add that if that is not, you know, if you're a person who doesn't fall into that category and you really just care about yourself, that if you are somebody over the age of 30 and you have at least one medical comorbidity, your risk of ending up in the hospital is actually pretty high. The new CDC data suggests that people who have 1 or 2 comorbidities and are middle-aged are at the same risk as people over the age of 60 who have no comorbidities of ending up in the hospital. So getting this infection for anybody is not risk-free. And the second thing to know is we're starting to recognize, and this has gotten a lot of press, is that there's a subset of people who get infected who feel like garbage for a long time, who suffer from fatigue, who suffer from real, you know, sort of low-grade memory issues that are not enough to impair their day-to-day life, but if they're working in a, you know, sophisticated high-stress job environment, it's enough to throw them off their game. There is, you know, some evidence of people having prolonged lung problems and issues of lung scarring, though that I think will be a longer-term story. So in general, you know, even if this weren't if you didn't have to worry about the issue of spreading to other people, it's still not something you'd want, you know. It's so.
No, yeah. We interview Ken, Zhang, and I on the Darkest Timeline podcast, available now, where podcasts are available. We interviewed Daniel Day Kim, and he has the thing about the brain effects, and he is an incredibly fit guy, and he was like, to this day, he feels like he's still getting over it. And I guess now I'm going to preach, but I was like, guys, as you just said, you do not want to get it, and you don't want to be casual about it. And this is the best time to be a hypochondriac.
what we've learned
right?
is really you don't have to be a shut-in. You can very much go outside safely. You can, you can get food from your favorite restaurant and pick it up safely. It's not that this is no longer, I think there were a couple of weeks there where we were all in the dark, and it felt like really that, how long is this going to last and what can we do safely?
Mm-hmm.
But it's no longer the case. I mean, you can get together with friends, just do it in a rational way. Go outside, meet them in a park, spread out. So it's not. It's no longer the
Yes.
requests that we're making of people are no longer draconian or even unfair. There's nothing that people should be whining about anymore. I mean, these are reasonable things to request of people in the middle of a pandemic. And so I really, I hope that we can somehow,
You can't emphasize it enough. Yeah.
Yeah, I'm getting asked
Would
this
you
a lot.
would you fly in an airplane right now?
It's a difficult question because there is a dichotomy between individual risk and thinking about it from the standpoint, well, if everybody made the decision I did, what would happen, right? As far as risk to other people. So I think, the truth is if you were to fly from a low incidence area to another low incidence area, so if I were to go from Seattle to San Francisco on a plane and take appropriate measures, I think wearing a mask and not touching anything and washing hands, the likelihood of getting infected is pretty low. But on the other hand, if everyone makes that decision, it has real ramifications. So the answer I've been giving people is ethically, I would not get on an airplane unless I had to. If I had to go see a sick family member, if I had to see somebody in need. So it's a slippery slope. And I that's not meant to be an absolute answer. I mean, I think people have to make their own decisions. But that's where we've thought about this a lot because we want to see our family this summer. And, it's not looking like we're going to be able to. And so it's not, I sympathize with why people would want to do it, but that's how I'm putting it together, is really saying, is this an emergency or not? And I do think that the airlines have an opportunity to make this a lot safer. I mean, I really wonder about the feasibility of testing everybody before they get on the plane. I think that seems like something that they should consider. It would obviously add to the ticket price, but in that case, I would feel a lot better about it. In terms of my own role in potentially adding to the pandemic in some way. So hopefully the industry will be clever about this to figure out a way to more safely travel. I mean, for what it's worth, I heard it's pretty miserable. I heard it's not very fun to be on a plane right now.
Yeah. Right. Well, yeah, I can't imagine because you're covered up and at least you're spaced out, so you don't have to be, sitting on top of people now. But now I know that we've almost been going an hour, but I only have 600 more questions, so this is great. No, we haven't. I know this came out, I guess, about 10 days ago, but for people who are in a severe situation, the use of that steroid seems to be helping. And if you could talk a little bit about that, and is that steroid? It's for arthritis. Is it similar to prednisone?
Different in terms of the indications it's used for medically. Whether or not that reflects a true difference in, if you were to use prednisone, whether you would get a different result is unclear to me. The nature of that study was that it was done in patients who were sick, so in the hospital, and it showed mortality benefit, which was great. And that it's like a lot of things in very sick patients. At the individual level, the impact is, so there's this statistic called an intent to treat, which is how many people need to get the treatment to avoid one outcome. So how many people do you need to treat to avoid a death? And depending on how you look at it, to me, it fell somewhere between 8 to 12. Okay. So if you're that person, not so great, right? I mean, the chance that it's helping you is relatively small. But then if you're director of an ICU and you end up seeing 40 COVID patients over the course of a month, you've potentially saved, 4 or 5 lives. And then if you then think about it nationally, that's a huge difference. So in that sense, it's a very good result, and it's comparable. There's subtle differences, but it's comparable to the remdesivir effect. Nobody knows if you add the two together, if you'll, increase the likelihood of success. And so that remains to be seen. I'm going to beat the drum again. I think with infectious diseases, we should be going for an intent to treat that's one. Everybody you give the treatment to gets better. I don't know whether that's achievable, but that should be our goal. And that's certainly the case with HIV. The intent to treat with HIV is not quite one, but it's very close, meaning that if you let somebody with HIV remain off treatment for 10 years, there's a very high likelihood they will develop AIDS and die. If you treat them, there's a very high likelihood they won't develop AIDS and they won't die. And so it's one of the reasons I went into HIV medicine is it's so incredibly satisfying that to know that the person in front of you is very likely to have a good outcome. And so to me, the way to get closer to one with SARS-CoV-2 is to treat early before people end up in the hospital, so that you're fighting a much smaller fire than somebody who's on a ventilator in the ICU, maybe is losing their kidneys, maybe, has incredible amounts of inflammation in their lung. And so I continue to think that if we're going to see more profound outcomes, that really catching people early is the way. And thankfully, since the last time you and I have spoken, there has been a decent amount of energy in that space, and a number of companies are exploring trials of all different varieties in outpatients. And so, I'm really excited about that, because I think that is potentially another ticket out of this. Whether we can get it all done in time, I'm not sure. But that to me, if we had to take this kind of awful approach of staggering towards herd immunity, I'd much rather do it treating everybody who gets infected, knowing that that treatment is effective, than just knowing that 15% of people who get infected are going to end up in the hospital, and and having that in the back of my mind. So I do think that remains this huge window of opportunity to treat early, to prevent the worst outcomes of the disease. Yeah.
Right. Well, I know you give me some hope, because from what you said, like if you were going to the restaurant, if you wear a mask, you stay outdoors, and are careful, hand washing, and you can still see your friends and all that stuff. Those are pretty simple steps that people have been talking about for months now, but they really absolutely do work, and they work. And I think you said it, but so I think right now people are terrified, and because the infection rate's going up. But it sounds like all you really need, keep that mask on and sanitize your hand. Be careful, but it's not that hard of a formula to follow, and you're cutting down the chances of getting it by a huge number.
And not only that,
I hope everything I just said was true.
We get to this place where the reproductive number is not floating around at 1, it's 0.2. The cases go down like they're going down in Western Europe, And then we can open up. Then we can go to phase 2 and phase 3.
Mm-hmm.
And not only can you eat outside at a restaurant, well, maybe you can eat inside, because the number of cases in your state is low enough to safely do that. So, you know, for people who really want their old life back, the fastest way to get there without bumps in the road is what I consider very mild sacrifice right now over the course of the summer and over the course of the fall, where we're all in this together, and we get the caseload low enough where we can gradually inch back to our old life. But if we keep doing what we're doing, it's going to be fits and starts and periods of time where we are really, you know, not able to send our kids to school, and all of these things that are just, you know, very tiresome at this point. So
very, it just, I think you said it perfectly, and I wish this was was on the banners all over the internet, but it just said mild sacrifice, and we'll get out of this thing in a much more comfortable way, and the economy can come back in a much faster way. All right, well, I've kept you for an entire hour away from your work, which I feel terrible about, but I really appreciate it. And people, I can't stress, you know, wear a mask. And you have the added risk of having to travel from West Seattle to Seattle, which I always bring up because I can't believe that bridge is closed.
No.
Any movement on the bridge? Are they tearing it down?
So. Yeah. Right.
See? Some things are worse.
Right.
We'll solve the virus before 5 years,
so
but people from West Seattle will still be taking back streets. All right. Well, I will let you go. I'll just get a catapult and launch one at you. But I know you have a lot of community and Are We Making a Movie questions, but we could not get those today. I know that you're dying to know. But I can't thank you enough, Doctor, for hopping on every other week and doing this. It puts me at ease knowing more stuff. So thank you.
Perfect number.
Let's have 5 beers when we get together. Yes, let's have 5 or 6. So cool. I hope to see you again in a week in a week and a half or something. So it'd be great. All right. So see you. Go Mariners. Go Seahawks.